And welcome to our second session of the Methadone in the Modern Era virtual series. I'm so excited to have so many of you here, and thank you all for typing in who you are, where you're from, and what your role is. It's really great for us to see who our audience is, as well as for networking purposes. We have an incredible treat for you today. Doctors Jessica Gray and Megan Miller are going to present on methadone in pregnancy, moving forward with policy and a lot of evidence-based care. So excited for this presentation. So one of the things I want to let everyone know is that we also have something coming up this fall, which is our Pearls for Practice conference. And that is going to be on Friday and Saturday in September, the 13th and 14th. And this year, we're going to devote a full day to methadone. So methadone is making a huge comeback, and we're very excited to be able to host her and all of her glory in the methadone day on Friday. And so please, when you see that, save the date, truly save the date. And then as soon as you see the sign up email come through, definitely sign up. We're very excited to have an incredible lineup. And then finally, I want to just pause and recognize one of our dear, beloved members of MASAM and an incredible leader in our state who we lost 2 years ago now. I can't believe it. It feels like yesterday. Dr. Barbara Herbert. And we have this incredible award to continue to think about her legacy and to present that energy and keep it going in our state and around the country, but particularly the New England area. So if any of you are thinking about a way that you can really push the addiction agenda forward and make a difference, please consider donating to this wonderful award that we have. And so now what I'd like to do is actually turn it over to one of our co-sponsors. Dr. Miriam Kamarami is the medical director of the Graken Center for Addiction through the Boston Medical Center. And as one of our co-sponsors of this methadone series, we are so excited to have her here to be able to introduce our two speakers. So take it away.
Thank you so much, Heidi. Good morning, everyone. I'm Dr. Miriam Kamarami. It's really such a pleasure and an honor to get to introduce our two speakers today. They're both really remarkable women and remarkable leaders in our field, and we're really honored to get to hear from you both today. So first, Dr. Megan Miller is an addiction medicine board-certified generalist OBGYN at Bay State Medical Center in Springfield, Mass. She leads outpatient and inpatient initiatives for pregnant people with substance use disorders at Bay State. She also runs a clinic for pregnant and parenting people with substance use disorders, which provides comprehensive care for these patients by providing integrated mental health support and collaboration with community addiction treatment and recovery support services. Regionally, she co-chairs the Hampton County Perinatal Collaborative. She's part of the Pinquin leadership team for the Maternal OUD Initiative, and she's a member of the DPH Maternal Morbidity and Mortality Review Team. Second, Dr. Jessica Gray is a dually board-certified family medicine physician and addiction specialist in the Departments of Medicine and Pediatrics at Massachusetts General Hospital. Dr. Gray is Associate Program Director for the MGH Addiction Medicine Fellowship and Medical Director of the Hope Clinic at MGH, where she cares for women with substance use disorders and their families from time of conception through the first 2 years postpartum. She sees patients at the MGH Bridge Clinic, which is a low-threshold outpatient substance use treatment clinic, and she's a physician consultant for the state-funded MICSTAP program, the Massachusetts Consultation Service for Treatment of Addiction and Pain. Finally, she's the president-elect of the Massachusetts Society of Addiction Medicine Board of Directors. Welcome, Dr. Megan Miller and Dr. Jessica Gray. We're so excited to hear your presentation.
Thank you. I'm going to share. Okay. So thank you so much. We're so happy for everyone that's here today. We're going to be talking about methadone in pregnancy, moving forward with person-centered evidence-based care and policy. These are our disclosures. We have a packed talk for you today. So what we're going to, our objectives today are firstly to understand the landscape surrounding patients on methadone in pregnancy, We're going to review metabolic changes of methadone in pregnancy and postpartum and implications for our current and hopefully changing future treatment system, and learn several ways that the postpartum period is uniquely challenging for birthing people with substance use disorders. So firstly, I'm going to start talking about the landscape surrounding patients with OUD in pregnancy. We're going to talk about a few things today, and I'm just going to get started. So we know that pregnancy is a time of opportunity for people with opioid use disorders. This graph here is showing overdoses in pregnant or parenting people in Massachusetts between 2012 and 2014. And what you can see is there are significantly fewer overdoses in the second and third trimesters of pregnancy compared to before and after pregnancy. And we think this is because pregnancy is really a time when people want to get healthier for their babies, and therefore they will be engaging in the healthcare system and with addiction care. And even if patients are not yet in care or on opioid agonist therapy, they're often engaging in harm reduction themselves, often by decreasing use or changing their use patterns. We also know that during pregnancy, people with substance use disorders drink less alcohol and smoke fewer cigarettes. However, unfortunately, significant barriers to care still exist within this population, such as stigma and bias, mental health conditions, childcare responsibilities, transportation challenges, technology challenges, fear of child protective service involvement, both during and after pregnancy, and racial inequity. And I'm going to discuss a few of those here. Oh, sorry. I'm actually good at technology, so. All right, so we're going to try, we could talk about statistics sort of until the cows come home, but we're going to try to bring this back to people. These are our patients. These are the people that we see every day. So I'm going to start with a case. This is a young woman in her 20s who's a G4P2 at 36 weeks and 6 days who presented to me for her first OB visit. So for those of you who don't quite remember OB, this is 1 day prior to being full term. So not ideal. She had very limited care, only one early ultrasound, one other visit at a different institution. She did get into addiction care. She went to a detox. And then when I saw her, was in residential recovery. She was on a stable split dose of methadone of 115 and 75. And her final dose at delivery was 115, 30, and 75. She had medical comorbidities, including anxiety and PTSD. She was Rh negative, but unfortunately, because of her late presentation to care, did not get RhoGAM as recommended. She had Hep C with a positive viral load, and she had gonorrhea that was treated in detox. And, like I say to all of my patients, when they present to care, I'm so happy that you're here. But my question to her is why, what took so long? And what she said was she wanted to be stable on methadone and not using drugs before she got into prenatal care, which is really not ideal. And unfortunately, something I hear a lot. And I think this speaks to several things, but one in particular is the significant stigma and bias these patients face. So most of you people here work in addiction, which means you're not strangers to the stigma and bias our patients and clients face. Society and even medical professionals may not recognize substance use disorders as a medical condition and instead consider it a moral failing that should be punished. In pregnancy, the stigma and bias is even more extreme. In our society, the quote unquote good mother is often idealized as a white, heteronormative, middle-class woman who values her family relationships above all else and will sacrifice anything, including her own identity and her health, for her children. So because of this, pregnant people who use drugs or even medications like methadone are viewed in opposition to this ideal. They become lethal fetal containers, and their ability to care for their children even after birth is called into question. Within this group, low-income mothers, which are very common in this group, and mothers of color face even harsher condemnation. The stigma and bias within both general society and the medical system is one of the many, many reasons these patients are less likely to seek adequate prenatal care during their pregnancies, despite often needing more medical and psychosocial care than the average population. And the more I do this, the more complex these cases get. And it's unclear if that's because we were getting older moms or if it's this poison drug supply, but the medical comorbidities are getting worse and worse. Another thing that can keep patients out of care is the racial inequity we see in addiction care and pregnancy. We'll talk about many of these throughout the talk, but areas where we see particularly concerning inequities include receiving any OAT, dose of OAT at delivery, urine drug testing at the hospitals, and mandated reporting and child welfare decisions. And here I just wanted to highlight this study, which showed that Black and Hispanic pregnant people with OUD in the study were found to be less likely to receive any OAT compared to white people. You can see that Black and Hispanic patients were around 60% less likely to receive any OAT. And with inequities like this, you can understand why a Black or Hispanic patient may not present to care or may present quite late, thinking, well, if they're not going to help me, why should I? This and other inequities we'll discuss later highlight how important it is to confront implicit biases, create institutional guidelines, and standardize care for patients with OUD to eliminate racial disparities. Okay. So back to our case for a moment. So we had a very, very swift initiation and completion of prenatal care. She got labs, and which included actually an unexpected seroconversion to a positive hepatitis B. She also had a positive trichomonas that was treated. She had weekly appointments for a few weeks, an ultrasound that showed an appropriately grown fetus with normal appearing anatomy, although it was quite limited due to gestational age. She saw our social worker, she saw lactation, she had a NICU consult, and we were collaborating with addiction care through a recovery coaching program, and her methadone split dosing was continued and titrated as appropriate. So at this point, we thought we were in a pretty good place going forward towards delivery and the postpartum period. But no matter how confident we are about our patient's status during pregnancy, we know that after delivery, the postpartum period can be a very challenging and unfortunately dangerous time for this population. This graph is showing, again, overdoses in pregnant and parenting women in mass between 2012 and 2014. And what you can see is that the overdose rates increase above baseline in the 7 to 12 months postpartum time. We don't know exactly why this happens, but it's probably a combination of factors that makes the postpartum period extraordinarily stressful and challenging, particularly when potentially balancing a newborn, obtaining OAT, as well as juggling mental health and recovery resources. And the importance of this trend is highlighted by the fact that substance use is one of the leading causes of pregnancy-associated deaths. This graph is showing that in Massachusetts between 2011 and 2014, there was an increase in the proportion of pregnancy-associated deaths related to substance use year over year. And in fact, in 2014, 1 in 5 pregnancy-associated deaths in Massachusetts were associated with substance use. And the concerning thing about these deaths for us as obstetricians is that they tend to happen later in the postpartum period than we typically expect to see these deaths. We expect complications like preeclampsia and hemorrhage to occur within those first 6 weeks after delivery, which is why we traditionally would see women for their quote unquote 6-week postpartum visit. But you can see that the majority of pregnancy-associated deaths related to substance use occur after the 6-week mark and up to 1 year postpartum. And during this time, substance use outstrips other causes for pregnancy-associated deaths. And at this point, we, as obstetricians, have often seen these women for their last quote unquote postpartum visit. And although we may try to have more prolonged follow-up, often pediatric visits start to take priority. So at this point, their addiction treatment and recovery support may be the only care that they're receiving. And again, I want to bring this back to people. We can talk about statistics all night, all day, but these are real people. So just some cases from our community. A woman in her 20s, late to prenatal care, delivered at home. We did initiate her on methadone, and she was linked to services, but she unfortunately died a few months after delivery in the setting of unprescribed opioid use. A woman in her 30s, limited prenatal care, put into the hospital in the 3rd trimester with a fetal demise. She had a new positive syphilis that was not treated, and she was lost to follow-up. And then a woman in her 30s who delivered a term, didn't disclose substance use until after delivery. DCF removed her child due to the drug use and also intimate partner violence. And unfortunately, she died of overdose the next day. These are our people. These are people, they're moms, they're our patients or clients, and we have the treatment and the tools to help them meet their goals. OAT is the gold standard treatment for OUD in pregnancy and postpartum because it leads to improved maternal and fetal outcomes and has been found to decrease the risk of postpartum overdose. In this study, this reached statistical significance at 4 to 6 months postpartum. This speaks to the need to keep women in care and continuing their OAT during this tumultuous first year of postpartum. And for the same reasons, it's also vitally important to talk to pregnant and postpartum people about harm reduction. For many people, it can feel uncomfortable to talk about to pregnant people about harm reduction. And now, now that they're growing a baby, it can feel wrong to promote anything but abstinence. However, pregnant people are already reducing harm before they seek care. And any harm reduction, one less bag, one less needle leading to one less infection, one less overdose is going to be beneficial for that patient and her child, whether she's engaging in care, just starting OAT, or stable on her medication. We should discuss harm reduction just as we do with non-pregnant patients, including safer use, reduced use, and Narcan, which is safe in pregnancy and saves lives. Reminder. We also discuss relapse planning and family safety planning for after the baby's born. And this is where I'm going to just address the elephant in the room, which is that when a person becomes pregnant, there's a fundamental shift in how they're viewed by society and the medical community. They go from being a person to being a vessel that's growing a baby. So we're going to encourage everyone to treat the person, and that includes continuing to provide counseling on harm reduction. Patients should be treated with dignity and support. They should feel safe where they are being treated and have the autonomy to make decisions after discussing risks and benefits to her and her baby. We're here to talk about methadone, and the way we talk matters. It's important. It improves outcomes, and although there may be small risks to the baby, the benefits vastly outweigh those risks. It's important that pregnant people consistently hear that they're doing the right thing and the safe thing for themselves and their baby. In this way, we can help patients foster the resilience to parent their children effectively. This is an amazing toolkit from perinatalharmreduction.org, and there's a QR code here where you can download that or go to the website. So to summarize, pregnancy and the postpartum period, which should ideally be joyful, can be a challenging time for people with opioid use disorders. However, we can help make pregnancy a better and safer experience by providing comprehensive, non-stigmatizing, trauma-responsive, and evidence-based care. So back to our patient, we did have a happy ending. She had a vaginal delivery at 39 and 1. She retained custody and residential recovery. She breastfed with much support from outpatient lactation and OT. She's having Hep B and C treated, but there were some real potential misses here, right? Because she came to care so late. She was at risk for alloimmunization because she didn't get a RhoGAM during the pregnancy. She and her hepatitis B, if she had come any later or we hadn't been able to get labs, we may not have known about that, and her baby would have been at higher risk for vertical transmission, particularly if it wasn't treated appropriately. So, the moral of the story is that we can do better. Patients shouldn't be afraid to seek care for themselves, their pregnancies, or their babies.
Great. Thank you so much, Dr. Miller, for setting all of this up. I'm going to then dive into the molecules or the molecule. So for part 2, I'm going to talk about the metabolic changes of methadone in pregnancy and postpartum and the implications for the treatment system. So methadone is a complicated drug because its pharmacologic properties and significant metabolic heterogeneity among individuals, and pregnancy actually complicates that further. So when you think about the physiologic changes in pregnancy, first we have enzyme changes. So CYP3A4 increases from the liver, from the placenta, from the intestine, and that increased metabolism, as well as increased of methadone, as well as increased renal clearance of methadone and changes in protein binding lead to patients processing methadone faster. You also in pregnancy have increase in women's body fat, blood volume of distribution increases, and that also leads to increased lipophilic storage, which we'll hear more about with fentanyl. And it causes dilutional effects as well for the methadone. So for all these reasons, pregnant people need active monitoring and dose adjustment throughout their pregnancy. And so I want to dive into the molecular level. When your patient tells you my dose isn't holding me, what does that really mean? So if you think about methadone as the parent, and the primary metabolite is EDDP, which is inactive. And so methadone gets N-demethylated from CYP3A4 and as well as some other CYPs like 2B6. Right, that you just heard really rev up in pregnancy. And so that means that whereas the half-life in the general population of methadone ranges from anywhere from 8 to 59 hours, which is an average of 24 hours a day, hence why we have daily dosing of methadone, that really, that rapidly changes in pregnancy. And so on average, the half-life of methadone in pregnancy can drop to around 8 hours. And that starts early in the first trimester. You'll hear a lot of teaching that wait till 3rd trimester to split the patient's dose. But I'm going to argue that no, a lot of your patients will show up and start to use or start to feel uncomfortable. And sometimes that's the first sign of early pregnancy. And how does that look? Again, it looks like my dose isn't holding me, right? I'm getting sick in the evening. And so I want to dive into the nerdiness of the talk, which is thinking about methadone levels. And so one that probably most people are familiar with, which has been around for decades, is the serum methadone level. This is when you get the peak, the trough, before patient doses, and then you get the peak 4 hours later. And if that ratio is greater than 2, that person is a rapid metabolizer. And if anyone works in a methadone clinic, this is a nightmare to get, right? You have to choose the right day where the patient comes, where the lab draw is there. You have to, ask a person to wait in withdrawal so that they can get their blood drawn before they dose. They then have to either stick around or come back 4 hours later to repeat the dose. The other challenge with the serum methadone level is that we actually don't have a good understanding, or we understand that the serum methadone level really doesn't predict dosing needs between patients. So while you can look at it within an individual patient, sort of can't make broad assumptions, between patients. So I want to turn to the methadone metabolite ratio, which is, again, the parent molecule methadone divided by the inactive metabolite, the EDDP. We can draw this any time of day. It's really helpful to get it at a peak or a trough to get a little more information. And the way it works is that a lower ratio points to more rapid metabolism, and a higher ratio means that the patient has a slower methadone metabolism. And so where did we learn about this? So McCarthy and al. have published a few important articles on the methadone metabolite ratio. And so in this study, this is for non-pregnant patients, they looked at 1,700 paired peak and trough methadone levels. And each category they found, when they separated out by the mean serum levels, the peak and trough paired, the ratios of MMR and half-lives, really each of these categories acted differently. And they were able to sort out folks who are ultra rapid metabolizers, extensive, intermediate, and ultra slow metabolizers of methadone. And so this is essentially measuring an individual's phenotype for methadone metabolism. So how do we apply that to pregnancy? Well, there was another study where they actually looked at pregnant patients, 23 pregnant people, and calculated their MMR in the various in the 3 trimesters and postpartum. And what you can see, just highlighting in red, the average of the MMR within each of those trimesters is anywhere from 7.2. It drops, it gets lower. So you have more rapid metabolism in pregnancy, and then postpartum, there's some increase back to potentially a baseline. And if you look again at the graph I just shared, all of those numbers, even though they dipped and decreased, all are on that left side, showing that these patients are all ultra rapid or extensive metabolizers. I always smile because this is my favorite graph. Pate in 2002 gets credit for this, but essentially what we're seeing here is that for patients who have a rapid metabolism profile, no amount of increased dose in blue for once daily dosing can get them in a therapeutic range all day, right? So you add methadone and you just increase their peak without actually, potentially making them over-medicated, over-sedated, without actually getting them in a therapeutic range all day. And therefore, split dosing really is essential to stay in that therapeutic range. And so how do I talk to my patients about this, right? So I said, for maternal stability, we really need to be constantly making dose adjustments during the pregnancy and postpartum period to keep you feeling normal, right? So I make sure they know that the dose increases that may be needed are really due to the changes in the liver metabolism of the medication, and they're not a marker of disease severity. So we are trying to just keep you feeling okay, and that's your liver processing faster. And really, we should be offering all women or all birthing people split dosing in pregnancy to maintain a therapeutic level. So this is one of my patients from several years ago who was really overjoyed to know that she was teaching others about this. And so she shares this data with you. So she required a pretty significant stabilization in the hospital in pregnancy, and was on such high doses that we actually got an MMR to understand what was going on. And so you can see as she's in there for stabilization, you can see this is a screenshot from Epic, what it looks like to order these. So you get the methadone levels, and then you get the EDDP. You can keep clicking. And what you can see, you can measure the peak and trough. But again, when someone's being titrated, it's not at a steady state, but you can see the methadone to metabolite ratio, right? Methadone over EDDP. And for both of those levels, the peak and the trough, this patient really is an ultra rapid metabolizer. And I'm just showing that, again, you can see where she falls on that graph. And really the only option for stabilizing this physiology is split dosing. So we talked a lot about moms. So what about the fetal well-being with split dosing? So there are a couple of studies, small studies I want to highlight. First, when they looked at fetal ultrasound, comparing a single dose methadone to split dosing. On the single dose, the fetus has lower fetal heart rate and reduced fetal motor activity at the peak dose, right? Versus when the methadone is wearing off at the trough, and that normalized on twice daily dosing. Similarly, right, when looking at sort of the motor activity, so before the dose, so when mom is in mild or moderate withdrawal at the end of her dose, we see a more active fetus, and then that declines after dose. Again, that normalized on twice daily dosing. And there's also a retrospective study that looked at split dosing of methadone, which actually had a lower rate of neonatal opioid withdrawal, which we'll talk about later, compared to sort of the general assumed rate of 60 to 80% at that point with once daily dosing. And so we have more to learn about in terms of the in utero environment and our understanding of fetal distress tolerant, but really this data supports that split dosing is beneficial to the pregnancy and the fetus to really stabilize the in utero environment. And I'll just, we were talking about this earlier, but thinking about fentanyl, as we're going to talk about more, right? This is a time where if someone is out of treatment completely and they're using multiple times a day, you can think about sort of the instability of that in utero environment. And again, the benefit of getting on treatment and getting on treatment that meets their physiologic needs. Okay, now I'm going to shift. And I love that there are so many folks at OTPs here, so thank you guys all for joining. And I really want to think about what is sort of the history of regulation and split dosing in pregnancy for methadone. So pre-COVID, there's really variable use of split dosing. It was considered a take-home. There were so many eligibility hurdles, right? Let's get you 90 days. You need to have, meet all these criteria. It was a lot of extra work for the OTP clinician to apply for take homes, right? You had to fill out the 8-point criteria. You had to apply, get approved. There were a few OTPs, and still are, that are open for twice daily dosing. So in order to get that second dose, it had to be in the setting of a take home. And then for those OTPs that do have, access to twice daily dosing, what human can get to a methadone clinic twice a day for their life and actually live the rest of their life, right? So that's unrealistic, a logistical challenge for patients. And so what happened is, right, not all OTPs were offering split dosing in pregnancy despite the evidence for it. It also, on the hospital side, for folks who are trying to stabilize pregnant people in the hospital, it was really hard to find an opioid treatment program that would accept someone on a split dose that also happens to be, right, where the patient is going for the residential or other treatment to fit their dispo plan. And honestly, that led to a lot of hospital teams just, not able to split dose when we had this opportunity to really stabilize someone with evidence-based treatment. And so COVID, silver lining, right? We had the 2020 public health emergency loosened the regulatory hurdles and expanded take-home flexibilities to 28 days, and that included split dosing. And then in 2022, SAMHSA codified those flexibilities, right? So we extended the post-public health emergency changes. So the take-home exceptions are not automatically required to initiate or continue split dosing, and recommended specifically, and I'll share the letter, that pregnancy split dose should be considered in all pregnant people. So this was the letter that SAMHSA wrote to all SODAs, really saying that we need to make it a priority, an evidence-based priority, that pregnant people And others who have rapid metabolism should get split doses, and those are separate from take-homes. All right, so what did our amazing State Opioid Treatment Authority say? Well, when we got these 2022 SAMHSA recommendations, they came out with clarifications and said, with relaxed SAMHSA guidance, our OTPs no longer need to apply for the split dose approval under the old 8-point criteria for take homes. That OTPs need to document in the chart the reasoning for the split dose, right? So such as pregnancy physiology. And thank you, Dr. Poti, for sharing this and some wording that you can write to get approved, right? So according to SAMHSA determination, decisions about split dosing do not have to be approved at a state and federal level. And finally, hot off the press, this month, the federal 42 CFR Part 8 final rule goes into effect. So it was announced and shared this in April, and it goes into effect. We have about 6 months for states to get in compliance with this. And really, it is a tremendously beautiful shift in how we think about treating patients with methadones, right? So the focus is really practitioner autonomy and patient-centered care. So, for example, patients can receive take-home doses really on entry to treatment based on clinical judgment, and it makes the 2020 flexibilities permanent. And I would say, right, we now have good evidence that wider access to methadone improves outcomes without increasing rates of diversion when it's paired with really thoughtful, individualized clinical judgment, safeguards and education. And so I really applaud, and I'm looking forward to seeing how our state can apply these flexibilities. So what are my take homes? I sort of gave them to you, but split dosing for pregnancy should be standard of care and universally offered for all of our pregnant people. Washington State has a model where they're piloting with their SODA actually universal access in all OTPs to split dose for pregnant patients who are interested in this. So worth looking at other states and how they're doing this. And otherwise, we really risk inconsistencies in treatment and really risk inequitable care across our state. So again, this new federal rule really supports individual policies that should be patient-centered based on clinical expertise and grounded in this growing evidence. And I would say, really, we need early evaluation for split dosing and close follow-up with the medical team. So how do we do that, right? There's limited data guiding the best practice for undertaking split dosing. It is really a clinical decision on an individual basis. So evidence points to splitting the dose much earlier in pregnancy. I would say don't wait till 3rd trimester. I know there are some places where, there's their rule on that. So yes, pregnant in 3rd trimester is where we see a lot of action, but don't wait to split dosing till then. Patients need it earlier. And then really, again, one of the other challenging is that patients need individualized assessment and adjustments by OTP. And that's real with staffing challenges and a doctor who may be only there once a week. And so, with these federal rules, it may be that we can think about how we staff OTPs to be able to provide more patient-centered care. Also, just in my experience, pregnant patients I take care of really underreport their symptoms. I'm always asking them, have you talked to your OTP, about what you're feeling? And really you have to get into the weeds, the details of their daily symptoms. And so ask them and educate them to please share how they're feeling on their methadone. And then I would say that the methadone metabolite ratio is absolutely not needed for clinical management, but it may have a role in complex cases. So I think it's valuable to know about. All right, so I can't talk about methadone without, and I'm sort of seeing the chat, but we'll talk later. But I can't, not talk about methadone without thinking about stabilization in the era of fentanyl. And so just want to highlight a few things. We know so much more about metabolism in pregnancy, and we have all these, changing OTP regulations, but our practices really aren't keeping up with the changing drug supply, right? So we have this poison drug supply with fentanyl that has been there for a long time now at this point. And start low, go slow does not work in pregnancy. We have I call it pregnancy privilege of being able to admit patients to hospitals for the sole reason of stabilization of substance use disorder in pregnancy. And we have had to really push push hospital titrations out of necessity to get people on a stable dose quicker, because otherwise we are losing them. They are actively using the hospital. They are, self-directing before they get stable and linked to an OTP. And so this is a really important area that is honestly under-researched, right? So there's only one published case report, but right now we have sort of every hospital and hospital system trying to figure out the best way to care for patients in real time. And also, I'd say this really, needs collaboration between sort of all levels of the care continuum to do this well. So why does this matter? In terms of thinking about racial inequities, again, another place where we see inequities is methadone dosing at delivery. And so some background information, we know from studies that a higher methadone dose at delivery is associated with treatment retention and relapse prevention in pregnant people. And yet, this retrospective study done an urban medical center showed that Black women or women of color received only 67% of the dose that white women do at delivery. And that was, with accounting for all other confounding variables. And that really, raises a concern that we are, again, having some really significant racial disparities and racism in how we treat pregnant people. And so I'm not going to go into the weeds here, but I'm leaving you all with the BMC Bay State obstetrical methadone titration protocol that you can find online, and the Mass General one, just to say that hospital systems are really, working hard to figure this out so that we can help stabilize patients in the hospital, and look forward to working with all you at OTPs to really be able to best support pregnant patients. So the summary of the literature of methadone dosing in pregnancy, right? This is the gold standard, with buprenorphine for treatment in pregnancy. We expect methadone requirements to increase, and we should really educate patients that this is normal and not a disease progression. We have seen in studies that a higher dose of methadone is correlated with less illicit drug use and vice versa. So, artificially holding doses or capping a dose is really not advised and is dangerous. And then finally, it's important that we all offer split dosing to patients for improved maternal and fetal well-being. All right. So that was part 2. Moving on to part 3, and I'm really excited to get to the chat when we finish. But I want to next start to think about with you guys the several ways that the postpartum period is uniquely challenging for birthing people with substance use disorder. And I think it'll touch on a lot of the comments in the chat. And so I'm always, one of my favorite quotes from Katie Raftery, who was our first recovery coach at the Hope Clinic, always said to us, the truth is getting through the pregnancy is the easiest part, right? And it's the postpartum that is so hard. So I'll start thinking about CPS reporting with that in mind. And again, methadone opioid agonist treatment is the gold standard in pregnancy, and yet so many people want to come off of it. And this qualitative study, national study, looked at the top reasons for discontinuation, and potential CPS involvement, right, is one of the critical ones. I'll also talk about neonatal withdrawal, the stigma that patients face during delivery, and then thankfully we don't lose insurance in our state postpartum. And in our state, and really in all of the US, these medical decisions in pregnancy are really heavily impacted by the broader social and legal context for medical decisions, which is really problematic. So I tried to summarize the federal guidelines for reporting on substance-exposed newborns without taking too much time. So essentially, right, we have CAPTA and CARA. You can go to the next slides. So CAPTA and CARA have come out in 1974 with a amendment, or the CARA Act that came out in 2016 with amendments in 2019 and 2018. And so to summarize all of this, essentially states are required to report or notify the federal government for substance exposed newborns that includes both legal and illegal substances. So alcohol, made sure that alcohol is in there, and are required to have create a plan of safe care for both the infant and the family, and are required to have a notification system that alerts the federal government for tracking purposes of substance exposed newborns. And what I would say is that, there is incredible variability. There was a study that came out in 2019 from Connecticut that really looked at how states are doing on meeting these federal mandates, and only I think 70% of states really really met the goals for one or two of these requirements. And so the summary is that states really have not been able to navigate these requirements in a way that meets the federal reporting, and also causes significant harm. And so again, as we think about those harmed in our society by misapplication of policies, we always think about the racial inequity. And so we know that Black mothers are 4 times more likely to be reported child welfare than white mothers, that Black children under the age of 5 are 20% less likely to be united with their families. And again, these qualitative studies, I'll share another one, reflect that the experience of stigma and fear of child welfare reporting impacts the maternal experience of parenting, engagement in treatment, and trust in providers. And a big part of that is reporting at delivery. And so we did a qualitative study in Massachusetts that came out last year, really looking at the negative impact of mandated reporting policies for prenatal substance use. And what we found is that these policies, so the automatic filing of abuse and neglect for a patient, especially if they are on, only on opioid agonist treatment, leading to neonatal withdrawal, leads to stress, leads to stigma, leads to what you heard Dr. Miller say, people are out of care and afraid to enter care until they're perfect, right? And this anxiety really does not lead to good outcomes. And so we really need to think about how to, and have been thinking about how to transform our landscape of treatment and reporting. So where are we in Massachusetts? I love to be able to update this slide every couple of months to really be able to say there is real exciting change on the horizon. And so the current Massachusetts state law for mandated reporting for opioid agonists in Massachusetts requires providers to file a 51A for suspected abuse and neglect for a substance exposed newborn or physical dependence of an addictive drug, right? And that is really that is being challenged in all areas of our state. And so there is now a combined bill, the H4392, which is an act relative to substance exposed newborns, which is the consolidation of a version of 2 bills. This is now the second time that bills have been up in front of the legislator. And as of the end of last month, it's been moving forward favorably from the Healthcare Financing Committee. And what this act does is really say we want to uncouple notification, which is a federal requirement, and reporting to child welfare. Oh, can you go back? Sorry. And I would also say that in terms of so the Department of Public Health, Dr. Goldstein, who is now the DPH commissioner in November of 2023. Also said from that angle, even if that bill doesn't pass, the DPH is working on a way for a dual reporting system to allow us to be able to, identify and count substance exposed newborns without needing to use the word neglect and abuse for families who don't meet that criteria. And thanks to federal legislation, we now have a Massachusetts statewide in-depth technical assistance that we're working on across the state to establish statewide definitions for substance exposed newborns, figure out how we actually collect this and report this data, and really figure out how as a state we implement plans of safe care, which are safety plans, essentially, held by the patient and their treatment team at delivery, which is the federal requirement that those exist. And then also there's individual hospitals and hospital systems that have been changing their reporting policies over the last couple of years.
Okay, so I'm going to talk next about toxicology testing, which is intimately linked with child welfare reporting, because unfortunately, child welfare and courts use urine drug testing often to make decisions regarding ability to parent. Historically, urine drug test was one of the first tests done on delivery admission for patients with OUD. And I highly appreciate that a lot of people here are from OTPs and so are doing drug testing in sort of a protocolized manner. But within hospital systems, it's also being done. And unfortunately, it's a test that's applied inequitably. The indications we are using for testing are often not evidence-based. Consent is been found to be inconsistent. And like everything else with this, fentanyl has complicated addiction treatment and monitoring. So bringing it back to racial inequity, this study from 2023 showed that Black pregnant people were more likely to be tested for drugs than white people, despite the fact that Black and white patients were equally likely to have a positive urine drug test. The indications for drug testing in pregnancy are often not evidence-based and are done without consent. This is a recent study from MGH that looked at unexpectedly positive urine drug tests. Of the patients undergoing urine toxicology testing, only 3.4% had an unexpected or positive test. And they separated these into high, middle, and low yield, with, for instance, in the top, pregnant patients with a history of recent SUD within the past 2 years were most likely to have an unexpected positive result versus indications that, believe it or not, are done in hospitals, like hypertension, and we're still doing testing for maternal cannabis use as well. And those have been found to be quite low yield. The next study looked at retrospectively at all urine drug tests performed over the course of 4 years in 5 partner hospitals and found that verbal consent was documented with only 30% of patients who received a urine drug test. And it was twice as likely to be documented in hospitals with established consent policies. So this speaks to the need between this and the racial inequities that we see. It speaks to the need for hospitals to develop consistent policies and guidelines that standardize this practice in an evidence-based way. Beyond its significant medical risks, fentanyl is also posing a significant psychosocial risk to pregnant people. Like I said, courts and child welfare sometimes heavily rely on urine drug testing to determine whether people are safe to take their babies home. However, the presence of fentanyl in urine drug testing, particularly on screening immunoassay, is not been found to be a good marker for active drug use in pregnancy. Like Dr. Gray said, the fat deposits in pregnancy increase. And what we've seen, and particularly in this case report, is that because fentanyl and norfentanyl are lipid soluble, we see this really prolonged excretion of norfentanyl in the urine. And in this case report, it was present in urine for over 70 days since last use. And, you know, in real life, we're seeing this all the time. So these are only 2 of my patients of many where I've seen this happen. And you can really see the difference between here active use and then this sort of slow and very prolonged excretion and sort of plateau of norfentanyl. Same thing here. And these will come back as a positive screen, and these confirmations take, you know, days and days to come back. Another problem with fentanyl is that although we sort of knew this was happening previously, this study proved that epidural fentanyl can be found in the urine of moms and neonates, both during labor as well as postpartum. And so when patients are getting urine drug testing done after delivery and there's a positive fentanyl, there is a chance that this is coming from an epidural. And so if a patient is accused of drug use, that's really concerning. There's also, as we all know, a potential for false positives. This is just a case series of 3 patients who had false positive fentanyl results only during a time when they were taking labetalol. Again, this all depends on what assays are being used, but this is a potential problem. And as we know, there are many false positives with urine drug testing. The ones in red are ones that we just use, or medications we use quite commonly in pregnancy or on labor and delivery. And so all to say that advocacy matters. Urine drug test results are more complex than they appear. It's really important that we send confirmatory testing if any action is going to happen on a positive result, whether that's medical or psychosocial. They're used, unfortunately, by non-clinicians to make life-altering decisions for families. And so it's very important that you provide expertise and advocacy for your patients whenever you can.
All right. Moving on to thinking about postpartum physiology. So we know that maternal function relies on optimal postpartum dose, right? Mom has to take care of baby, take care of herself. If her dose of methadone is too high, she risks oversedation, overdose, safety issues for the baby that we all worry about. And if it's too low, right, we have a mother who's withdrawing, who destabilizes and can have a return to use. And so the challenge is that we actually don't have good evidence as to how long it takes for a patient to return to pre-pregnancy metabolism. And a lot of people are entering the treatment system during pregnancy. And so some women may not have even reached their therapeutic dose. And so how do we do this? What do we do with the limited evidence for postpartum methadone adjustment? Well, again, going back to individualized care, right? Patient-centered care, dose adjustments should be individualized, and you need close monitoring in the postpartum too. Again, I think there's more to learn in terms of methadone metabolites in the postpartum period, but for now it's absolutely clinical assessment. And so I want to highlight this case. So this is a G2. She has a history of opioid, stimulant use disorder, benzodependence and misuse, trauma, depression, anxiety, seizure disorder, and a history of endocarditis. And she has been on methadone for 7 years at around 90 to 100 and never really stabilized. She's unstably housed, has active intimate partner violence and polysubstance use, including, struggling with her prescribed benzodiazepines, clonidine, gabapentin, with moderate adherence. And so she comes in for prenatal care. She gets wraparound outpatient multidisciplinary support. She has low threshold care at the beginning when she, is struggling to engage. She has 3 hospital admissions during pregnancy to help stabilize her medication regimen. And ultimately, she is able to remain in residential level of care and downtitrate her synergistic meds. And so you see at 25 weeks, so second and third trimester, you can see that her methadone metabolite ratios circled there are low, right? She isn't becoming a more ultra rapid metabolizer in pregnancy. And so, we had to use this actually to support her in getting a split dose from her OTP successfully. She delivers on a split dose, and then, she's getting her dose reconsolidated in the several months postpartum and, is over-medicated, but again, required a blood level to demonstrate that she is still a rapid metabolizer. And actually, I don't put a ton of weight on seromethanone levels, but if you look at her peak at 784 compared to her other peaks, and, with her clinical appearance of being over-medicated at that peak and her rapid metabolizer, this is important to know that this patient, may have been a rapid metabolizer in pregnancy. We may not have been optimally treating her for the last, decade of her life, but she actually does really well and is now, considered a rapid metabolizer outside pregnancy and has stabilized on split dosing even outside pregnancy. And I just raised this to say that, individualized care can't stop at delivery, right? That, non-pregnant people too are going to be rapid metabolizers and are going to need that level of assessment to keep them feeling okay. So neonatal withdrawal is the next thing we want to talk about. It is on everyone's mind. It's what our patients ask about on day 1 in pregnancy, as they're considering medications in pregnancy, and they hear lots of stories. So this is what I share with my patients. So when they ask what impacts the severity of neonatal withdrawal, and the first is that methadone dose has not been shown to matter, right? So the dose of mom's methadone does not correlate with severity of neonatal opioid withdrawal. You should be on a dose that makes you feel normal all day. We do have evidence that buprenorphine, through the Mother trial in 2010, has less withdrawal effects than single dose methadone. So I'll add, question mark, will that change as we move to a different standard of care? But right now, buprenorphine does have less withdrawal. We know that babies' genes play a role. And then importantly, other substances have been shown to increase the severity of NAS. So we have benzodiazepines, SSRIs, gabapentinoids, which are, a few of them. And, the idea is to optimize and reduce exposures and optimize while optimizing maternal mental health. And then I would say nicotine, right? This is, one that we really see cause especially the first 24 hours of irritability and withdrawal in babies. And finally, it's our hospital NAS treatment protocols that have historically separated moms and babies that have led to higher rates of requirement of pharmacological treatment for NAS. So we know that, parent presence and skin to skin and breastfeeding are first line treatment for neonatal withdrawal. And those hospitals that have shifted to more of a dyadic model of treatment, such as eat, sleep, console, PRN dosing of opioids for rescue medication, have seen a significant reduction in the need for pharmacologic treatment and length of stay for babies. So overall, more severe symptoms are likely a combination of the genetic predisposition, multiple exposures, and hospital policies. And I'm going to shift it to Dr. Miller to talk about breastfeeding, which fits in there as well.
Yeah, so like Dr. Gray said, breastfeeding has been found to reduce the severity of NOWS, but not necessarily simply because of the breast milk, because we know the amount of medications that are actually found in breast milk is quite low. And in fact, it's probably the other things that are surrounding breastfeeding that actually decrease the amount of medications and the severity of NOWS in breastfeeding, things like parental presence, cuddling, skin to skin, things like that. And so again, coming back to a case which is something that we unfortunately are seeing relatively commonly in the hospitals and is complex. So this 20-year-old G2P1 with OUD on methadone is post-op day 1 from her primary section for non-reassuring fetal status. She used illicit opioids until approximately 2.5 months prior to delivery. And on admission, her quantitative test is positive, her qualitative test for fentanyl is positive. However, she did have some urine drug tests in the outpatient setting that were positive screens, but negative for confirmatory fentanyl with that very low level of norfentanyl that we had talked about earlier. And she wants to breastfeed. So what happens next is sometimes, unfortunately, unfortunate, which is she receives a lot of judgment, a lot of misunderstanding, and is ultimately told, I don't think so. Right, which is really, really devastating for these patients that are very motivated to give their babies breast milk. So I wanted to frame this question in the setting of the Academy of Breastfeeding Medicine 2023 update with some sort of call response that we often will hear in the hospital. So the first thing is she should not breastfeed if the urine drug test is positive. So the ABM guidance highlights that urine drug testing can be used to inform breastfeeding guidance, but has significant limitations. And this is particularly true with the prolonged fentanyl and THC clearance that we see in pregnancy. And it specifies that these do not represent active use. What they recommend is that breastfeeding should be avoided when testing is consistent with new or ongoing non-prescribed use. And, what I like to remind everybody is that parents don't want to harm their newborns. So if we do counsel them on the risks, most commonly patients are going to want to do what's best for their babies. So what are the risks of non-prescribed opioid use with breastfeeding? So for the neonate, we can see sedation, withdrawal, respiratory depression, and the long-term impacts aren't known. For parents, we don't want them using non-prescribed opioids because they could be more sedated, unable to respond to infant cues, and there's an increased risk of bed sharing injuries. Something else you might hear is she used drugs within the last blah days of delivery, so she shouldn't breastfeed. And this actually comes from the previous guidance from ABM, where they did actually say that breastfeeding should be avoided if non-prescribed substances were used in the 30 to 90 days before delivery. However, evidence has shown that most substances are eliminated in hours to days rather than days to weeks. And so they specify that women who discontinue non-prescribed substance use by or during delivery hospitalization can be supported in breastfeeding initiation. Okay, so we'll support her in breastfeeding initiation, but the big question becomes, can we give this baby this milk now? And this is where really it becomes important to have multidisciplinary approach and shared decision-making with the patient. And this is particularly true in this specific case, which is, again, something we see not uncommonly. We don't have a lot of data on this prolonged low-level norfentanyl clearance in neonates, but especially when there's not been recent use, and especially if it's been weeks to months, we expect that most likely this really small amount of norfentanyl is unlikely to be clinically significant. And many centers that are doing a lot of this work have equated a quote-unquote declining quantitative urine fentanyl level as compatible with initiation of breastfeeding. So what if, okay, we go to her, we have this positive screen, and she says, you know what, I did use yesterday, a couple days ago, whatever it is. So what we can do is still, but I still want to try to give my baby breast milk. We can still support milk expression to establish milk production. And so that includes getting the patient a breast pump, talking about manual expression, a lactation consult. And then we want to allow time to pass for illicit substances to clear from milk prior to offering it to the newborn. We know that the majority of non-prescribed substances will clear usually within 72 hours, including unchanged fentanyl. And this is a QR code here for the ASAM pocket guide that has like all of the different substances and how long they most typically take to clear. So that can be really helpful. And this is, again, a space where multidisciplinary institutional guidelines are important to guide length of abstinence. So some of them say at least 72 hours, and also need for repeat urine testing, for example. And then the other question, what if she leaves the hospital and starts using again? For any patient, it's important to discuss relapse safety plan prior to discharge, that to have patients be able to identify a safe caregiver for the baby, availability of formula for feeding if needed, to advise them that breast milk in the case of a lapse should be expressed and discarded, and make sure that they consult with their team if it happens. And it's really important for this population to provide targeted perinatal dyadic lactation care and multidisciplinary FCD treatment. So I put this as a reminder that all medications for substance use disorders are safe in breastfeeding except for acamprosate and varenicline. We do support breastfeeding with all those medications. These two resources are ones I like a lot. For other medications, especially since these patients tend to be on multiple psychiatric medications, I like Hell's Meds a lot, but you have to pay for it. NIH LactMed is free. And then just a resource for typically how long some of these drugs stay in the system. So my take homes on breastfeeding: infant feeding wishes should be supported in a patient and family-centered way. Urine drug testing should be used in clinically meaningful ways to guide breastfeeding initiation, but has limitations. Individuals who discontinue non-prescribed substance use by the delivery hospitalization can be supported in breastfeeding initiation with appropriate follow-up, whether that's breastfeeding and actually giving milk, depending on the situation, or pumping to establish supply if there was recent use. It's very important to have perinatal dyadic lactation care and offer that to everyone that's interested in giving mother's milk, because historically this population has often not been given that opportunity routinely. And then multidisciplinary guidelines should be established to standardize care. So in summary of our presentation, understanding the landscape, pregnancy represents a unique opportunity for engagement in addiction care, but it's fraught with challenges, including stigma and bias, racial inequities, and limited access to evidence-based care. Addiction care in pregnancy requires compassionate, multidisciplinary, person-centered care. Changes in methadone regulations, metabolic changes in pregnancy and postpartum require active monitoring and titration of methadone. And luckily, changes in methadone regulations are lining up with the concept of individualized care, which should really be embraced. And delivery and postpartum are uniquely challenging for birthing people with SUD. Families deserve a supportive, multidisciplinary approach that collaborates with community partners while centering on the needs of the family during pregnancy and the postpartum years. Thank you.
Thank you both so much. This was absolutely incredible. And I was already thinking, I can't wait till it gets posted on our YouTube channel because I want to watch it again already. So Jess, I know that you have been looking through the chat. Would you like to start to respond to things, or would you like me to moderate people's questions? What would be best for you and Megan?
Yeah, I was trying to respond where I could. So I think if you want to moderate, that would be amazing. And yes,
Absolutely.
this will all be posted, and so we're happy to share.
So one of the things I'd love for you guys to talk about is just a little bit around the shared decision making when you're talking to patients who are choosing to be on methadone versus buprenorphine. And then the second thing is, if you have a patient who's on methadone, a single daily dose, and appears to be doing well, is it necessary to split the dose to improve the outcomes? And so if you could say something about those two things.
I can start. Okay. So yeah, I tried to answer this. Whenever I talk to patients, I share that we have two good, really excellent evidence-based medicines in pregnancy. And the most important thing is the medicine that works for that patient and that they can access, right? So there are so many practical barriers to both getting on medication, right, and to being able to continue it. And so I really walk through an understanding of what the patient can do, what's been successful in the past. There are some studies, I think, that someone alluded to, saying that there are lower withdrawal rates for buprenorphine. Again, we didn't study that with a split dose methadone, so it's hard. I think that while that's true for what we know, I do think that I wouldn't discount methadone because of that. It is also really hard to get on buprenorphine in the age of fentanyl, and I think methadone is just a really important medication that should be treated as such and really offered, because it is as Heidi always says, it's a magic medicine that really does help people make better. And so those are the conversations I say. And either medicine, when you look at untreated opioid use disorder, all of the sort of benefits of being in treatment, including, making it to, full term and gestational age, birth weight, et cetera, are improved with treatment. So that is how I say it. I think the other question you asked is about if someone is perfectly stable, should you split their dose? And no, that you don't need to force someone to be on a split dose, right? I think, again, this is patient-centered care. We think everybody should be offered the opportunity to split their dose based on what we know. But at this point, it very well could be that that person is completely feeling normal, and is the rare person who feels okay throughout their pregnancy. I think I would just talk to your patients about, we're just going to keep paying attention to your symptoms. And if you start to feel uncomfortable overnight, if you're, itching to get to your clinic for the next dose, it could be a sign that your metabolism is changing.
No, that's super helpful. Megan, would you say something further about split dosing as well? One of the things that I've noticed is that people use the word split dosing, and it makes them feel like it's supposed to be a 50-50, and that's the end of the story. And that's clearly not what we're talking about. We're talking about generally twice daily dosing, but I was struck by your first case that it appeared that you had 3 times daily dosing. So could you say something about the idea of what a true split dose means?
Yeah, and it's interesting because I don't think we have really any data on this per se, except to say that it's really all individualized care and how people are feeling and what makes them comfortable. So, I see, and I don't personally work at an OTP, but what I see in my patients is anything from a 50-50 split to more commonly a higher dose in the morning, and maybe like 2/3 of that dose in the evening. And then, I think it's where patients, when you can get a really good individualized history from a person of where they're feeling uncomfortable, and that you can really individualize those doses. If you're starting to feel comfortable in the middle of the day, then instead of increasing that morning dose or increasing that evening dose, either adding a small afternoon dose, which happened with this patient, or splitting rather than increasing, sometimes patients prefer as well, can be really helpful for them. So it comes back, I think, to that individualized care and getting a good history and really asking patients to describe their symptoms.
That's great. I think one of the other areas that's really been active in the chat is the issue of DCF, particularly here in Massachusetts, and the recent Globe article regarding how Mass General has reinterpreted what is appropriate. Could you say more about the difference between the reporting versus the notification, and just this whole piece around DCF and how we can advocate better for our patients to be able to parent if that's their choice?
Yeah, I would say, so Massachusetts is behind the 8 ball in this, right? Other surrounding states have already moved to a dual reporting system and have been doing that for years, right? So the federal, and sorry, my newest slide didn't actually update for the presentation, but like federal guidelines are mandating a notification system, right? So a de-identified notification to track substance exposed newborns. And so states, other states around us are actually making that that distinction of not requiring a filing to say that this person abused and neglected their fetus and now baby, but that we're collecting this data to improve outcomes. And so I think that we're moving in that direction, right? So DPH, there's a bill in the legislation to really make sure that we are meeting federal standards while of collecting that data, while also thinking about the harms that are potentially keeping patients out of care for being on medication for treating their use disorder.
Thank you so much. And I think since we have a few minutes left, there's one question that has popped up, which is regarding MODA. And could you say something about the areas where that piece of advocacy should really be part of our work and how that impacts pregnant and parenting people?
Yeah, MODA is a really important act for all of us to get behind and support. So this is federal legislation that will loosen and improve flexibilities and access to methadone across the country, right? So we need to sort of unchain methadone from OTPs that are really, not accessible for so many people in our state and federally. And so, yeah, I would really encourage everyone to write to your legislators and to support MODA as an opportunity for pregnant people and not to really be able to get care from addiction experts that meets their needs and is accessible.
Thank you so much. We actually do have 2 more minutes. And so if there are additional questions that people feel strongly about, you can certainly post them in the chat. The other thing I wanted to say too is that the issue of how you define a take home for the flexible criteria is something that comes up often. And I did clarify this specifically with BSAS to ensure that we all have the same definition of a take home here in Massachusetts. And that is, if somebody is receiving a single bottle every day to take their evening dose, that is considered one take home. And if you then give them both bottles, so they are not dosing observed, but it is a single daily dose that they are getting in 2 different bottles, that is also one take home. So you don't count the number of bottles, you count by the day's dose. So just to clarify, 1 day's dose is either 1 bottle or 2, and it doesn't matter how many bottles are given. If it's a single daily dose, that counts as a single take home. And so that hopefully helps clarify what people are eligible for in the flexible take home era.
There was a question about the prolonged fentanyl clearance in urine drug testing. This is an area where I think regarding pregnancy, so Dr. Poti had said that they're seeing patients who are taking 4 to 6 months postpartum to get negative screens. And I'm not seeing a lot of the postpartum only because, like I said, a lot of these patients unfortunately fall out of obstetric care at that point, not by our choice, but rather by unforeseen circumstances. We're seeing months, really months of norfentanyl in pregnancy, we think because of that volume of distribution and fat stores. And it seems that in the postpartum space that this is also being seen, with that changing physiology, breakdown of fat. This is probably why we're seeing that, but it's something that really needs more study and more sort of case studies out there, because it is extraordinarily common and really, really distressing to patients and sometimes causing poor child welfare outcomes.
All right, we have reached 8:15. Thank you all so much for the incredible discussion and for your presence here. And thank you, big thank you to Drs. Miller and Gray. This was amazing and riveting. And like I said, it's going to be on our YouTube channel, and I feel like I'm going to watch it again tonight. So again, thank you all so much for the work you're doing in our community too. And we're looking forward to seeing you in September at Pearls for Practice. Thank you all so much. Have a great day.